Welcome back to Cancer Buzz TV. I'm your host, Summer Johnson. This is the final episode of our two-part series on anemia mitigation and care coordination for patients with MDS. Today, we're zeroing in on ways to reduce frequency of in-person care visits when managing anemia in patients with low-risk MDS. Our guests today are Dr. David Sallman, Associate Member in the Department of Malignant Hematology at the Moffitt Cancer Center in Tampa, and Karley Trautman, a hematology and oncology nurse practitioner and senior instructor of medical oncology at Highlands Ranch Cancer Center in Denver. Dr. Sallman, can you share best practices for managing anemia in patients with low-risk MDS?
Yeah, so really the focus is all around the symptom burden that a patient may have. So if a patient is asymptomatic, really independent of hemoglobin levels, a lot of times we'll just observe and monitor those patients closely. But if a patient is dependent on blood transfusions, this is essentially starting if a patient has a hemoglobin of less than 7, or there's kind of a gray zone between a hemoglobin of 7 to 9 grams per deciliter, where again, if patient's significantly symptomatic, we would start blood transfusion. That's really the foundation or the sort of support system for patients, both to keep them safe as well as to improve their symptoms. And then the focus on top of that is once a patient is symptomatic, or particularly if they are dependent on blood transfusions, we will work to initiate them on therapy to mitigate that, and not just mitigate the need for blood transfusions, but ideally to improve them to a hemoglobin level that their symptoms are actually markedly improved. This really was a challenge in the past when we had limited options, but now that we have more options, we can really focus much more around the patient experience and making them feel better in that setting.
Karley, how can healthcare providers strategically reduce the frequency and intensity of care while maintaining effective management of anemia?
Yeah, I think that also goes back to really focusing on how the patient is doing. Two people that have the same hemoglobin level can have completely different symptoms. And so it's really important that we don't just focus on the numbers, but we focus on how the patient is feeling and how they're functioning in their life. So that if they are doing well, even at a lower number than something that we might typically treat, that we don't let that number drive how often we feel like they need to be seen, but we take it into the account the whole person.
Dr. Sallman, how do you see telemedicine and remote monitoring technologies contributing to that flexibility?
Yeah, I mean, I think this is. I mean, we all have this, right? We all do televisits quite frequently. I think the challenge has been is sort of the networking with the sort of home health. So how logistically is the hemoglobin going to get checked with a, let's say, a rapid turnaround, or again, does this have to be coordinated to the day prior to the televisit? They get it so that the result is there. We do sometimes have patients where they do get local values, and we help use that to dictate, hey, should next cycle of whatever uh be initiated. But I think that's the hurdle that's been there. There's not a very streamlined connection between what we can do from a telehealth perspective and what can be done from a home or remote monitoring perspective. And I think if somebody could bridge that gap, both either components of the pharmaceutical world or other, I think that could actually greatly help this whole process.
Karley, how does shared decision making come into play here?
Yeah, it's important. The problem is that we as healthcare providers want to fix the numbers and we want the numbers to look good. But it's so important that we understand what the patient's lifestyle is, what their goals are, and what is most important to them, because we want to tailor our treatments to then focus on those things. If the most important thing for the patient is that this disease um, has the least amount of impact on them, then asking them to come in frequently for blood draws and things like that probably don't meet those goals. So we need to know exactly what the patient's um, main goals are, and then what their biggest side effects and problems are. And we need to go after those more than we need to go after what I, as a healthcare provider, feel like makes the patient look, the best.
Dr. Sallman, how can we improve collaboration with the primary hematologists and oncology APPs?
Yeah, so it definitely requires a whole team. It includes, again, as you said, the PA or nurse practitioner. It includes pharmacy. It includes nursing staff, infusional centers. The other big challenge is just around blood banks. So for big academic centers, it's really not a problem because we have blood banks in house. Whereas really the vast majority of community centers have to then work on this collaborative either with their local hospital or infusion center, and actually creates an additional burden from that perspective. But I think once that's essentially established, again, it can be relatively straightforward. Again, I think the goal is though still personalizing it for the patient. So say, hey, this patient, they feel markedly better when their hemoglobin is greater than 10 grams per deciliter, as an example, and thus really focusing the therapy. So you still either titrate or transition therapies until you achieve that. At the point of achieving it, again, you come up with some interval. Usually, it's the interval of the frequency of the therapy. The least frequent therapy is usually every 3 weeks right now, and you just kind of go and say, hey, if the hemoglobin level is at this, you continue. If it gets high, you may hold. If it gets low, again, thoughts about transitioning earlier in order to again make the patient's experience better.
Thank you to you both. You can head to the show notes for more on anemia management in patients with low risk MDS. And if you haven't already watched the first episode in this deep dive series, you can find a link to that in the show notes as well. This episode was made possible through support from Bristol Myers Squibb. Until next time, from all of us here at Cancer Buzz TV, thank you for watching.